In this lecture, we will discuss left ventricular hypertrophy, including its EKG features and potential causes. Hypertrophy refers to an increase in muscle mass. A hypertrophied ventricle is thick and powerful. Ventricular hypertrophy is often the result of pressure overload in which the heart is forced to pump against an increased resistance. Just as weightlifters develop bigger and stronger muscles by moving progressively heavier weights, the heart muscle grows thicker and stronger when having to eject blood against an increased resistance. When the ventricle hypertrophies, the flow of electricity through the heart changes, and so does the axis. Normally, the electrical axis is somewhere between -30 and +110 degrees. However, if the left ventricle hypertrophies, there will be greater posterior and left lateral electrical forces. Okay? So if you look here, again, the left ventricle hypertrophying, we have an increase in posterior and left lateral forces. Okay, so here's our right ventricle. This is our left ventricle. Now we're going to say there's an increase in mass, all right, that we may see. Here's our aortic valve. Maybe it's stenosed, okay? In such cases, we have to pump against a greater pressure, or a person with hypertension. And because of that, now we're going to have our vector that's directed more posteriorly, okay? And this is this yellow vector here, as well as leftwardly, okay? This is the left, and it's heading more posteriorly where the left ventricle sits, okay? So that's what we see going on here. Now let's go through the EKG criteria here in our chart. But first, it should be noted that the EKG diagnosis requires both the voltage and non-voltage criteria. The voltage criteria have to do with the voltage or the amplitude of the QRS complexes, okay, or the waves of them, while the non-voltage criteria has to do with everything other than the amplitude changes, such as the ST segment and T wave changes. Okay, we're going to start with the voltage criteria, then we'll move to the non-voltage criteria, all right? And we'll separate the voltage criteria into the limb and the precordial leads. Now remember, we're looking at the QRS complex. Why is that? It represents ventricular depolarization. So all our changes here will be in our QRS complex. Remember, with atrial abnormalities, we look at the P wave, which represents atrial depolarization. Okay, so now we have our voltage criteria. We have the voltage, and then we'll look at this non-voltage. So in the voltage, in our limb leads, we're going to look for an R wave in lead 1 plus an S wave in lead 3 that's greater than 25 millimeters in amplitude. Okay, so again, just so you're aware, this is our R wave, this is our S wave. What you're doing is taking the number of thick lines or boxes, the small boxes, and remember, each one small box equals 1 millimeter. Okay, and then one large box equals 5 millimeters. Okay. So what we're saying is we're going to take the R wave, so the amplitude in our R wave, and we're going to add that in lead 1 to the S wave in lead 3. Okay, so then you would take another one, and you take, so this one from lead 1 and the S wave from lead 3, all right, the depth of it, and you're going to add that together, and if it's greater than 25 millimeters, that meets that criteria. Okay, now another one is looking at the R wave in lead 1. Okay, and the R waves in lead 1, okay, look here, should be greater than 14 millimeters. Okay, so all these have to do with voltage. All right, so these are all with the R wave. The next thing would be an AVL if you have an R wave that's greater than or equal to 11 to 12 millimeters. Okay, and I put those ranges because you'll look at a bunch of criteria, and some will say 11, some will say 12. So just so you're aware, 11 to 12 is generally accepted. Okay, and then an AVF, 20 to 21 millimeters. Okay, and that's all with the R wave. So remember, R wave is the first positive deflection after the P wave. Okay, next we have the S wave. Okay, this one here, and AVR. So now you're looking at AVR, and you're going to look at the S wave depth. Okay, again, this portion here, and in that case, if it's greater than or equal or greater than 14 to 15 millimeters, that would meet that criteria. Okay, so that's the limb leads. Then we have the precordial leads. Okay, and one of the most common criteria you'll hear about is this first one, which is the Sokolow-Lyon criteria. Okay, it's most commonly used, and if you remember any of them, I would remember these. Okay, you can go in your free time and try to memorize all these other numbers, but this one's the most commonly one used. Okay, and what you do is you look at the S wave in V1 or V2. Okay, so if we look, here's V1 and here's V2, and we're going to look at the S wave. Okay, this is our R wave. These are our S waves. Okay, and we're going to add that, whatever's deeper, okay, so you're going to take, in this case, we'll take V1 because it's a greater S wave compared to that in V2, and we're going to add that to the taller R wave in V5 or V6. So here's V5 or V6. This is our R wave. This is an S wave, okay, R wave, S wave. Because the R wave's taller in V5, we'll use this one, okay? And what we're saying is that we're going to take V1 and add it to V5, and that amplitude should be greater than or equal to 35 millimeters, okay? So simply put, here's our R wave, V5 or V6, take that, and you're going to add it to the S wave in V1 or V2, and that should be greater than or equal to 35 millimeters in amplitude, okay? So really, you can think about that as 7 large boxes, okay? What do I mean by that? So let's look at V1. We have from here until this point, that's 1 large box. Until this point, it's 2. Until this is 3 and 4. So we've had 4. We just need 3 more to make the voltage criteria diagnosis of left ventricular hypertrophy. So what we do is now look at V5 and we add it to this, okay? In this case, here's our first one. 1, 2, 3, 4, 5. Okay, so it's well beyond 35 millimeters, beyond our 7 large boxes. We actually have 9 large boxes. Okay, and how many small boxes would that be? Well, 9 times 5 is 45 small boxes, okay, or 45 millimeters, which is beyond that 35 millimeters that we need. Okay, so that's one of the key criteria. I want you to really know that one so that you can use that in your clinics. Okay, now other ones in the precordial leads are looking at the R wave in V4, V5, or V6, and you want that amplitude greater than 26 millimeter, okay? So you don't need all of these, okay? These are just different criteria that you can use. So again, the R wave in V5, V4, V5, or V6, okay? And remember, here's V5 and V6 we can look at, and we're looking from this point until here, okay? That's our R wave, okay? And then we're the other one. So here's V4 through V6. You can use this as your amplitude of the R wave. Okay, the next one is in V5. It should be greater than 26, just like the other one, the previous one. And another one is V6 greater than 20. So as you can see, there's a number of different criteria. Some seem to clash, but this is because there's so much that has been proposed. Okay, and that's why I want you to remember this one that's the most commonly one used. Okay, the other thing is, if you take the largest R wave and the largest S wave in the precordial leads, so remember precordial leads V1 through V6, whatever the largest R and the S wave is, and if you add that together and it goes beyond 45 millimeters, that suggests left ventricular hypertrophy. Okay, all right, so that's our voltage criteria. Now let's take a look at the non-voltage criteria. First, we can see an increase in the R wave peak time, or we call the intrinsicoid deflection, that's often greater than or equal to 45 milliseconds in leads V5 and V6. Remember, normally the intrinsicoid deflection is less than 45 milliseconds in these leads. All right, so what is our intrinsicoid deflection? Do you remember? Let's just erase some of this so we can have some room. There's a lot going on here. So, okay, here's our QRS complex. The intrinsicoid deflection is from our QRS onset, from this point, to the R wave peak, okay? And you're taking that width there, that duration, and normally in V5 and V6, it should be less than 45 milliseconds, okay? Sometimes with left ventricular hypertrophy, it can be beyond that. Okay, so that's one thing to note. Now there may also be a slight increase in QRS duration, and this is due to an increase in the myocardial mass, okay? More mass to go through, more ventricular depolarization, so things are going to just take longer. In addition, we can see secondary ST segment and T wave changes, which represent ventricular repolarization abnormalities due to the hypertrophied left ventricle. This has been referred to as a left ventricular strain pattern. Some suggest that this has been going out of fashion and no longer using this term. But I put that there. So usually now they use the secondary ST-T wave changes. Okay. Now in these cases we would see downsloping in the of the ST segment. Okay, downsloping ST depression and asymmetric T wave inversion in leads V4 through V6. While we would see in leads V1 through V3 concave ST elevation and asymmetric upright T waves. Okay. So this is just like when we talked about right ventricular strain pattern. Okay, now this one is our secondary ST-T wave changes that are a result of repolarization abnormalities. Okay, so here's V1 through V3. Okay, and remember in V1 through V3 you're looking for concave ST elevation, which is this portion let's use a different color. This portion up here, it's concave up, so we call that ST elevation, okay, above our baseline here, and it's concaved up. And you'll also see that upright T waves in these leads. So here's our T wave, and notice that it's upright, okay? And then in the left lateral precordial leads, V4 through V6, okay, what you see here is downsloping ST depression, all right? Here's our baseline. Notice that we're below it, okay? So that's ST depression. It's going downwards, and we're also seeing this T wave here that's inverted. So we have T wave inversion, okay? So pretty much the opposite. Notice that we have pretty much discordant changes, an upright main QRS complex that's going up, and then ST depression and T wave inversion going down, okay? And then in this case, we have a deep S wave, and then we're going to see ST elevation and upright T wave. So we call those changes discordant, okay? And these things can help support and are part of that non-voltage criteria, okay? So now there are some other EKG features that can help support the diagnosis of left ventricular hypertrophy. The first one here is P mitrale, which is a sign of left atrial enlargement. We would see a notch P wave with an increase in duration in lead 2, as well as a duration in depth of the terminal P wave in lead V1. So let's go over those changes. Again, we have a lot here, so let's just erase this. So we can look at lead 2, and we can look at lead V1, okay? And this is P mitrale, a sign of left atrial enlargement. In lead 2, remember, we can see those M-shaped P waves, okay? So this is a P wave. The duration will be greater than 110 milliseconds, okay? So about 3 of the small boxes. We'll see this notching of the P wave where this interpeak duration is at least one small box, 40 milliseconds, okay? And notice you can remember that because it's shaped like an M, so P mitrale, okay? The other thing, in V1, we can see biphasic P waves, okay? In this case, we're looking at that terminal portion of our P wave, this portion here, that represents left atrial depolarization. In this case, our changes will be at least 1 millimeter wide by 1 millimeter deep, okay? That's one way that can suggest left atrial enlargement, okay? So next we can see leftward axis shift in the frontal plane between -30 and -90 degrees, which is due to those increase in the leftward forces. Okay, so just to erase some of this here, notice that our arrow, our vector, is now heading more leftwardly, okay? And if we look at our axis here, this is our normals between -30 and +105 or +110, around that region, okay? And what we're seeing here is because of those increased leftward forces, we'll see leftward axis shift, okay, between -30 and -90 degrees, okay? And lastly, prominent UAs may also support that left ventricular hypertrophy. Generally, they are proportional to the QRS amplitude. In other words, as the QRS amplitude increases, so would the U wave amplitude. All right, in terms of causes, we have a few listed here, including systemic hypertension, aortic stenosis, aortic or mitral regurgitation, coarctation of the aorta, and hypertrophic cardiomyopathy. Obviously, what we're saying here is if we can block this or increase the pressure, we'll thicken this left ventricle, okay, and it will hypertrophy in order to compensate and overcome that increased stress. Now, one last thing I want to mention are factors that can potentially influence the amplitude of the QRS complex. These include the distance between the heart and the electrodes. If it is increased, okay, like in obesity from the adipose tissue or COPD from hyperinflation, the amplitude will appear lower than expected. The opposite is obviously true in a thin individual. They'll generally have greater QRS amplitudes due to the closer proximity of the electrodes to the heart. Another factor is age. As individuals get older, the QRS amplitude tends to decrease. In addition, females tend to have lower QRS amplitudes than males. And lastly, athletes have been found to have a greater QRS amplitude, which has been attributed to ventricular remodeling. The main thing here is to consider these influencing factors when you're interpreting the EKG, because obviously we've seen with this voltage criteria, a lot of them are based on what the amplitude is, okay? So if the patient has COPD and you have hyperinflation or they're obese and increased adipose tissue, that increased distance will diminish the QRS amplitude, okay? And it can affect some of our reading and what we see for left ventricular hypertrophy, because obviously you can see these are based on certain voltages throughout. All right, let's briefly review what we discussed before we end. So again, left ventricular hypertrophy is often a result of an increase in stress or resistance in the left ventricle. Because of that, we see an increase in these posterior and left lateral forces. Remember, the EKG diagnosis requires this voltage and the non-voltage criteria. Remember the voltage criteria, there's a number of them listed there, okay, where we looked at the R and S waves mainly, okay, so you can go through these and try to remember them. There's quite a few. The main one I want you to remember is this Sokolow and Lyon criteria. With the S wave in V1 or V2, you're taking the deeper S wave and you're adding that to the taller R wave in V5 or V6, and it should reach at least 35 millimeters, okay? There's also some other criteria there that you can use and keep handy in the clinic. Now, other thing is this non-voltage criteria, okay, where we saw an increase in the intrinsicoid deflection, all right, should be greater than or equal to 45 milliseconds in V5 or V6, and there could be a slight increase in the QRS duration, which is a result of the increase in left ventricular mass, okay. We can also see these secondary ST and T wave changes, where we saw in the leads V4 through V6, the downsloping ST depression and asymmetric T wave inversion, as well as the concave up ST elevation, okay, and asymmetric upright T waves in V1 through V3. And really the main thing here is the greater let's just show this here, the greater the S wave is, the greater the ST elevation, okay? And the greater the R wave, you'll see, the greater the ST depression you'll see, okay? So again, that discordance will be proportional to whatever the QRS amplitude is. You'll see that. We mentioned some supporting evidence of left ventricular hypertrophy, P mitrale, which is a sign of left atrial enlargement, left axis deviation because of that shift in the forces more leftward, and the prominent U waves that are proportional to the QRS amplitude. There's a number of causes. Here's a few listed. And remember the factors that influence the QRS amplitude. Obviously, the distance between the heart and the electrodes, okay, can influence the amplitude. The age, as we get older, it tends to decrease in amplitude. Females tend to have a lower QRS amplitude than males, and obviously athletes will have an increased QRS amplitude, and that's often attributed to ventricular remodeling. Well, that's the end of this lecture. We discussed left ventricular hypertrophy, including its EKG features and potential causes. I hope you learned something.